Welcome to our Advanced Pathophysiology lecture on coagulation. Our objectives for this lecture, first off, it's important that you review the role of clotting factors and platelet plug formation in homeostasis. And this is your responsibility because I know this is review for you, but if you haven't had a chance to think about that and review some of the normal, you might want to do that. We'll talk about the transition of normal clotting into the pathophysiology of thrombus formation. We'll differentiate between inherited and acquired coagulopathies. Then we're going to talk about VTE, or venous thrombus formation. We'll talk about Virchow's triad. Then we'll turn our attention to some of the common causes of both hyper as well as hypocoagulable states. When we do that, we'll be able to determine the difference between idiopathic and thrombotic thrombocytopenia purpura. We'll talk about how bleeding disorders related to coagulopathy differs from thrombocytopenia. And then lastly, we'll talk about the pathophysiology of disseminated intravascular coagulation. Now, I realize that those of you in primary care are not as likely to see DIC as those that work in higher acuity environments, but it is an important clotting disorder that we should all be aware of. So let's start off by just a few introductory remarks, and that is about hemostasis. Well, the whole idea behind physiologic hemostasis is to stop bleeding, and we know that we need to be able to do that if we're going to survive. However, too much clotting as well as insufficient clotting is problematic and a potential threat to our homeostasis. I think a lot of times we think about the first two essential steps in hemostasis. We think about the platelets and we think about coagulation. We tend to focus here, but we know that that's only part of the full system. We know that the full system not only includes the formation of clot through platelet plug and coagulation, but also that clotting has to stop and that clot has to be broken down via fibrinolysis. We need to remember that that full process is a physiologic process, but can also lead to pathology. Because we know that once the thrombus forms and essentially does its job, it has to be physiologically broken down as well as removed. And we do that through fibrinolysis. Fibrinolysis includes enzyme breakdown of fibrin. It includes activating the tissue plasminogen activating system, and it also includes phagocytosis. Remember those important housekeeping function of the phagocytes. So when you think about hemostasis and you think about clotting, it's important to think about this on the full continuum of initiation of clot all the way through lysis of a clot that has formed. Remember that we focus a lot on that coagulation cascade, and I know there are gobs of and many steps in that. And I'm going to refer you to the extra handouts as well as the graphics in your text. There are great graphics, and those of you that are very visual learners, you can follow along with your textbook open as you continue to solidify some of these pieces that we're going to talk about in your mind. We know that the coagulation cascade includes about 12 plasma proteins, many or some of which require activation by enzymes. So we know then that many of our coagulation products, our coagulation proteins, circulate in an inactive form that then have to be activated through our enzyme system. So for example, factor 9 has to be converted to factor 9A in order to work, factor 10 to 10A. And we always know that those mechanisms are in their active form when you see the little a in front of it. Also recall that our clotting cascade has a dual pathway. We have the extrinsic and the intrinsic pathway, and it's important that you know the differences between these pathways. Our extrinsic pathway is our primary pathway. This is what happens when we have damage to the tissue. And generally it's outside the vessel wall. This is what we measure by our prothrombin time, our PT. The intrinsic pathway supports and amplifies the primary pathway, so it supports and amplifies the extrinsic pathway. In this, the blood is exposed, so we have damage to the vessel wall itself. You'll see multiple conversions in that intrinsic pathway from those inactive to the active forms, so 10 to 10A. We measure this pathway by the activated partial thromboplastin time, or the APTT. Now, commonly we just refer this to as the PTT, and we leave that little a out, but remember that'll help you remember that this is intrinsic pathway. We also remember from our normal our normal physiology rather, that the extrinsic and the intrinsic pathway join and feed into the common pathway. So this is where they come together in the clotting mechanism, and it's about near the end of the mechanism. The common pathway starts with factor 10, which then is converted to factor 10A. Factor 10A then stimulates factor 2, which is prothrombin. Prothrombin converts to factor 2A, or thrombin. Under the influence of thrombin, then, the production and the release of factor 1, or fibrinogen, is stimulated. Factor 1 converts to factor 1A, or fibrin, and that fibrin is what forms to trap and form that fibrin meshwork, and that fibrin trap is important in our clotting mechanism. So as a result then, when you're measuring the common pathway, you need both the time, the prothrombin time, as well as the activated partial thromboplastin time. And once again, these are the manifestations that we talk about in this course. So extrinsic pathway, primary pathway measured by your time. Intrinsic pathway supports and amplifies that extrinsic pathway and is measured by the partial thromboplastin time, the activated thromboplastin time. Our common pathway is where the intrinsic and extrinsic pathways come together. So if we want to measure the activity of our common pathway that starts with factor 10 and the conversion of factor 10 to 10A, we would then need both the time as well as the activated partial thromboplastin time. In our understanding, so how do we then use that in understanding pathophysiology? So let's start off with some very general ideas that we'll come back to. In general, there are two very common classification of coagulopathies. They are generally either inherited or acquired, and it's important to understand the differences, both on the difficulty clotting as well as the hypercoagulopathy state. So when we look at inherited coagulopathies, we have to think about those that are characterized by difficulty in clotting, and this is what we see in von Willebrand disease, which is the most common inherited hypocoagulopathy. We're going to come back to that and talk more about that. In the inherited hypercoagulopathies, the most common is factor V Leiden. You may also see protein C deficiency and protein S deficiency. All three of these inherited hypercoagulopathy states are autosomal dominant disorders. Von Willebrand disease is also autosomal dominant. And again, we're going to come back and talk about both, all of these inherited coagulopathies. When we think about acquired coagulopathies, once again, this can be either difficulty or a hypocoagulopathy, which means difficulty in clotting, or it may be a hypercoagulopathy. So when we think about acquired difficulties in clotting, shouldn't surprise you that I'm going to give you one of the more commons, and that is in uremia. In someone who is uremic, who has either a substantial kidney injury or has chronic kidney disease, that uremic environment is a very poor environment for effective clotting. So you might see you may see difficulty clotting just because of the uremia. On the hypercoagulopathy state or hypercoagulable side, the three things you might want to think about are antiphospholipid antibody, cancer, and pregnancy. So let's go through each one of those briefly. So with antiphospholipid antibody, this is an antiphospholipid. Antiphospholipid we know phospholipids are on our cell surfaces, and the individual builds antibody to those antiphospholipids. Then those antibodies then encourage clotting. So what type of immune disorder might you see this in? Yes, you'll see this in autoimmune disorders like lupus or rheumatoid arthritis. Pregnancy, a lot of what you'll see in pregnancy has to do with venous stasis. And if those of you who have undergone pregnancy, remember in late stage pregnancy, when the pregnant uterus, the gravid uterus gets very, very large, it frequently can put pressure on the femoral vessels, and venous return can be slowed, therefore causing venous stasis. So even though you'll see an increase in blood volume during pregnancy, you may also see hemoconcentration a little bit with that pregnancy as well. Cancer is something that I wanted to set aside and talk about specifically, because individuals who have cancer can develop an acquired hypercoagulopathy and therefore are more likely to develop thrombus. What happens with the cancer is that the tumor cells actually have the ability to release procoagulants. They also release factor 10 activating protease, as well as, remember that cancer is pro-inflammatory, and those cancer cells are releasing inflammatory cytokines. So when you think about the hypercoagulopathy states that are associated with cancer, you've got three ways that those cancer cells are problematic as it relates to clotting. The tumor cells release procoagulants, they release factor 10 activating proteases, and they release inflammatory cytokines. All three of these encourage clotting. We also want to consider age ranges when we think about clotting and homeostasis. We know that as we get older, especially as we get into our late 60s, 70s, and on into our 80s, 90s, and 100s, that there is a shift toward increased clotting and decreased fibrinolysis. So if we have a shift toward increased clotting, you'll see an increase in thrombus formation. So advanced age is a risk factor for the development of thrombus. However, at the same time, there is a decrease in fibrinolysis. So as we get older, we're more likely to clot, and our physiologic clot removal system is less efficient. So that then shifts us more on the clotting side. Let's also talk, though, about newborns. When a child is born, they have decreased ability to clot. Now, some of these may be genetic disorders, and we may not know that initially when the child is first born. But those of you who work pediatrics and those of you in neonatal, you can help your colleagues out. Why do we give vitamin K to a newborn? Got to dig deep on this one, don't you, for some of us? Yes, remember that vitamin K is synthesized by our GI normal flora. So our GI bacteria actually synthesize vitamin K. When we are born, our GI normal flora hasn't had an opportunity to populate and begin to produce the vitamin K. That's why we give vitamin K to a newborn. Other things to consider, remember the coagulation factors are proteins, and this is true at all ages, not just at geriatrics. So consider nutrition protein calorie nutrition. Think about liver function because that's where we make many of our coagulation factors. Think about what's going on throughout the entire organism. Again, regardless of age, the risk factors for venous thromboembolic disease are the same, but they become more common as we get older. So when you think about risk factors for developing VTE or venous thromboembolic disease, we think about as we get older, have we decreased our physical activity? Do we have more chronic inflammation? And in many cases, we have an increased number of comorbid conditions that can alter our clotting or the removal of the physiologic removal of small clots that we also make physiologically. Let's turn our attention then to looking at some issues with thrombus formation. And when we think about spontaneous thrombus formation, now again, we're talking spontaneous thrombus formation here. We want to look at three major factors, and this is where Virchow's triad really helps you out. I'll just say it this way. Hint. This is a triad you need to have an understanding of. These three factors are important in our understanding of spontaneous thrombus formation. So those three factors in Virchow's triad include venous stasis, vessel damage, and hypercoagulable states. Let's take a closer look then at all three of these because they matter in pathophysiology. So in venous stasis with Virchow's triad, we know that venous pressure is less than arterial pressure. So as a result, you have a decrease in the velocity of flow in the venous system. When you slow that down through stasis, you increase the probability of the formation of thrombus. So once again, we're going to think about elders, individuals with vessel disease. What about individuals who are obese? Pregnant women, yes. The second part of the triad is damage to the vessel. And remember, we're thinking about damage to the endothelium. Remember that vessel injury activates that intrinsic pathway that is going to amplify the extrinsic. Last but not least, hypercoagulable states. We just reviewed both inherited as well as acquired, but in Virchow's triad, let's think more about the acquired side. So on that acquired side, we talked about malignancy, we talked about pregnancy, we talked about antiphospholipid antibody. But we also want to think about some other things that may be applicable to an individual. Elevated levels of homocysteine have been implicated in an acquired hypercoagulopathy. And we know that high levels of estrogen, women who take birth control pills, which have a lot of estrogen in them, that is also a risk factor for the development of thrombus. The most common pathology that we think about when we think about the spontaneous development of clot is thrombosis or thromboembolic disease. So let's take a look at this common pathology. With VTE or venous thrombosis, you can see that the annual incidence is actually pretty high. We want to remember that VTE does not, and we look at epidemiology, there's no gender preference, although, as we've talked about, more likely to occur in elders, but also more likely to occur in African Americans. We've already talked about the risk factors, so I won't go back over them at this point. So when you look at those risk factors, I want you to keep in mind two big pieces. One is the Virchow's triad that we talked about, but also remember the impact, the potential impact of inflammation and the inflammatory response. Certainly, not only is immobility implicated in post-op and obesity, but in the post-operative state, we know that we have an inflammatory state going because of the surgical procedure, and obesity is pro-inflammatory. I'm not going to talk a lot about pulmonary embolus simply because pulmonary embolus is a pulmonary disorder, but the thing that we do want to remember about pulmonary embolus is the highest risk of a pulmonary embolus is in someone who has a proximal deep vein thrombosis. Now we know that DVT is that deep vein thrombosis, but we know that venous thrombosis can occur in any in any vessel. It's more common in the lower extremities than in the upper, and we know that venous thrombosis in the lower extremities can be distal or it can be proximal. PE is more likely to occur when you have a proximal DVT. Now, again, as you know, we don't talk about treatment in this course. However, I think sometimes it helps us to remember how as we're trying to understand clot and hypercoagulable states, if we think about how we do treat this. And when we treat venous thrombosis, when we treat embolic disease or thrombotic disease, our treatment is aimed at physiologic transition points in that clotting cascade. Our preventive strategies are also aimed at physiologic transition points in that clotting cascade, as well as decreasing other risk factors like immobility. If you're interested in reading a little bit more about some of the newer anticoagulants, there's a great article in the September 2016 Journal for Nurse Practitioners by Solomon and Hume. And what Solomon and Hume did in that article is just in a very easy read, I think, looked at oral anticoagulants and specifically identified where in physiologic transition points those pharmacologic agents work. Now, you're going to see this again in Pharm, but if you want to do a little reading or if you're interested for your own practice, it's a good article. Okay, so now let's look at other pathologies. Let's start by looking at hypercoagulopathies. Now, as you look at these three, factor V Leiden, protein S deficiency, what are those? Those are what kind of disorders? Yes, those are genetic disorders that we already identified as being inherited pathologies. So let's look at both factor V Leiden and the protein S deficiency. Factor V Leiden is an autosomal dominant disorder, so that means that the individual needs one gene in order to manifest the phenotype or the disease. We've primarily, and this is a very common disorder, we look for this in unprovoked deep vein thrombosis. So you've got someone who essentially comes up with a spontaneous clot and you really can't figure out why they have this. It's estimated that about 30% of individuals who develop DVT actually have a factor V Leiden defect. So what's the issue here? Well, the issue here is factor Va. Factor Va, remember factor V is activated to factor Va. So what happens is that in this disorder, 5A isn't being inactivated by protein C, and that's what's supposed to happen. 5A facilitates clotting. Protein C is there to turn it off. As a result then, because you don't have the inactivation by that protein C, the factor 5A continues to contribute to clotting. The coagulation product isn't being broken down, it isn't being stopped. As a result, you continue to make the thrombin. So what you have to then remember in this is, what does protein C do? When protein C is activated, it inhibits coagulation, therefore is an antithrombotic. So just remember, protein C inactivates factor 5A, which is the activated form of factor V, and so this disorder is called factor V Leiden. So what about a protein S deficiency? Protein S deficiency is also autosomal dominant. Protein S assists in the activation of protein C. So protein C, as we talked about before, inactivates 5A. So, if you don't have enough protein S, you don't have enough protein C, and once again, you have too much, you continue to have the activity of 5A, and in that environment continue to clot. So again, in our thinking, protein S and protein C are antithrombotic proteins that help us inhibit physiologic coagulation. Those proteins both help with the balance between pro and anticoagulation at the endothelial level. Once again, homeostasis, all about balance. Antiphospholipid syndrome. We've touched on this before, and we've talked about that this could be acquired but is frequently associated with autoimmune diseases, and as a result there's a wide variety. You've had the opportunity, I hope, to explore this a little bit with lupus. We see this in rheumatoid arthritis, two fairly common autoimmune disorders. So what happens in this, in the autoimmune disorders is the individual produces antibody against coagulation factors. So they may produce antibody against prothrombin, protein C, protein S, against platelet activating proteins. Let's turn to the other side and let's talk about hypocoagulopathies. Now, with hypocoagulopathies, think of hypocoagulopathies in two major categories. One major category will be a decrease in the clotting factors. The other big category deals with platelets. When we look at platelets, platelets may either be unable to function, or you may not have enough platelets, therefore leading to a thrombocytopenia. So the other thing, before we go to the two disorders here, is when we think about the manifestations of hypocoagulopathies. Remember, we talked about the two major categories, not enough or insufficient coagulation factors, or platelets and platelet issues. When we think of manifestations, when we think of the manifestations of insufficient coagulation factors, you're more likely to see deep bleeding, and by that I mean bleeding into tissues, into joints. This is very different than what you'll frequently see with platelet disorders. With platelet disorders, whether it's decrease in function, which is usually an adhesion process, or a decrease in number, you're more likely to see the development of petechiae, those pinpoint hemorrhages that you'll see at the surface of the skin. Okay, so now that we know that there are two major categories and that they manifest a little differently, let's talk about them separately. So let's talk first about platelet disorders. There are two platelet disorders that we'll talk about. One is primary immune, and the other, which is an idiopathic thrombocytopenia purpura, or ITP, and the other is thrombotic thrombocytopenia purpura, or TTP. And forgive me, but I'm going to refer to these as ITP and TTP, but it's important that you be able to take it out all the way, and I know you'll do that in your study. So when we talk about ITP, this is much more common than TTP. So ITP is it's idiopathic, but it's frequently preceded by a viral syndrome and is also time limited, and that supports the idea of an idiopathic disorder. So let's go through these steps. So what you'll see in ITP is you have platelets, but those platelets are being phagocytized by the macrophages. When those platelets become phagocytized by the macrophages, remember that macrophages then present these particles to the CD4 cells. When those macrophages present these phagocytized platelets to the CD4 cells produce IgG. And IgG is an antibody. Those IgG antibodies then bind to to other platelets. So you start with these platelets being phagocytized for whatever reason. So they're being phagocytized by the macrophages. The macrophages present them to the CD4 cells. The CD4 cells make antibody, IgG antibody, and those antibodies then bind to the platelets. As a result then, what do you think these platelets are going to do? Nothing. They can't function because the platelets, those binding sites, those IgG antibodies that have bound to their platelets, keep the platelets from functioning physiologically. So as a result, when you think about this as a peripheral disorder, not a central pathology. So what that means is when we think about a central pathology, you're thinking about production. This is about function. If we were thinking about production, I'd be worried, or the central pathology, I'd be thinking about bone marrow function. Bone marrow is making platelets, but because of the antibody binding to the surface of those platelets, they cannot function. So what you'll see here is those petechiae, but you will not generally see a life-threatening bleed because you do still have some platelets out there. So you'll see a decrease in the platelet count, but you generally don't see a dramatic drop in that platelet count like below 50,000 where you would worry about spontaneous bleeds. Now that is different from TTP or thrombotic thrombocytopenia purpura. This is primarily an autoimmune disorder, or in children, look for a genetic cause of this. And in kids, it is more likely to be a genetic disorder, and it becomes a chronic, relapsing, remitting disorder. Now, this is much less common than ITP. Now, let's talk about it, though. The key to TTP is that there are increased amounts of von Willebrand factor. First, let's talk about normal. Normally, von Willebrand factor increases the adhesion of platelets at the vessel wall. And this occurs when an enzyme breaks down the factor and allows then the factor to actually work. This enzyme is a protease, and it's ADAMTS13. Remember, there's an enzyme there, and just think it's an atom TS13. So in TTP, this enzyme, this ADAMTS13, is absent. And if you don't have the absent, you're not breaking down the factor, and if you don't break down von Willebrand factor, it cannot work. As a result, then, the platelets cannot adhere to the vessel wall. However, what's happening, even though those platelets can't stick to the wall, because remember that's what von Willebrand factor does, so the platelets can't stick to the wall. However, they're clumping with each other. And so as a result, they're not available to form that platelet plug. So you have platelets that are clumping together. They're not available to work well in your clotting cascade, and that's why we call this a consumptive coagulopathy. So you've got platelets. The enzyme isn't there to break down von Willebrand factor and without von Willebrand factor, those platelets can't stick to the vessel wall. When they can't stick to the vessel wall, you don't have that clotting at that site of injury. However, even though they're not sticking to the vessel wall, they're sticking to each other, and while they're not forming the platelet plug that they're supposed to, they're clumping with each other, and that's why we call it a microvascular thrombosis or a thrombotic purpura. This is a consumptive coagulopathy. When you look at labs then, you will not see an effect on the coagulation factors. Your PT and PTT are normal. And while you once again may see some decrease in the platelet levels, it's not a huge dramatic decrease in the platelet levels. It's all about their function and what they're doing. As this continues to develop, many individuals will develop a hemolytic anemia, primarily due to the autoimmunity and the autoimmune dysfunction. And you'll see, as we said, maybe a little bit of a decrease in the number of platelets, but you will see microvascular thrombus formation. Microvascular thrombus formation is because of those platelets clumping in the microvasculature. Now let's look at another example, but this time let's look at coagulation factor effects. And we're going to look at the hemophilias. The two most common hemophilias are hemophilia A and hemophilia B. Now the hemophilias we first became really aware of this in the royal families of Europe in the 16, 17, and 1800s. And this occurred in the royal families of Europe, and you would see this going through these royal families because there was a lot of intermarriage during those decades. So let's look at both hemophilia A and B, and then a few words about an acquired hemophilia. The overwhelmingly most common type of hemophilia is hemophilia A, and this represents about 80% of the hemophilias. Hemophilia A and hemophilia B is an X-linked recessive genetic disorder. So this means that the mutated gene is on the X chromosome. Remember, the X chromosome is the female chromosome. But it causes the phenotype, as in many X-linked genetic disorders, to be expressed on the Y chromosome, and the Y chromosome is the male chromosome. So as a result, with hemophilia A, generally what you will see, because it is an X-linked recessive disorder, and it's expressed on the Y chromosome, you will see this in males. However, because it is X-linked, the male cannot transmit this disorder to the next generation because the male doesn't contribute that Y chromosome to females, and their X wouldn't carry it. I hope that made sense. When you go through the genetics, it'll make a little bit more sense. But what I really want you to understand is that this is an X-linked recessive disorder. The mutated gene is on the X chromosome, attaches to the Y chromosome, and that's why generally you will see this expressed in males, and much less commonly a homozygous female. What you'll see in hemophilia A is a deficiency in factor VIII. So remember that in normal physiology, factor VIII circulates in an inactive form bound to von Willebrand factor until there's tissue damage, and then it disconnects from von Willebrand factor and forms with factor X. So what you'll see in these individuals, because they have the deficiency of factor VIII, platelet count is normal, prothrombin time is normal, but you'll see a prolonged activated PTT, intrinsic pathway. Hemophilia B is less common than A, but is also an X-linked recessive disorder. Hemophilia B, however, is a deficiency of factor IX. Once again, you will see normal platelets and normal prothrombin time, but a prolonged activated PTT. So how do you separate these out? Once again, you have to get a good family history, and you can actually measure the clotting factors. With hemophilia A, since that is the most common, remember that this is intrinsic pathway, and what did we say about manifestations of coagulation factors? How do those usually manifest? Bleeding into the joints, into the muscles. And with hemophilia A, this can occur without overt injury. So what would happen, or what does happen in individuals with hemophilia A, is they may jump off a playground swing, and that jarring injury to the joint can actually cause bleeding into the joint, whereas a child who doesn't have hemophilia wouldn't have any negative impact at all. So remember that with coagulation factor defects, you're going to look for bleeding into joints, into muscles, and frequently without apparent injury. There is also an acquired hemophilia that is quite rare, and this is usually an autoimmune disorder, and it causes the development of antibodies to factor VIII. And I include that for completeness. Now, just because we can and we should always talk a little bit about what's new in science, there's actually a new therapy that's in phase 3 trials for hemophilia. And I think the focus has been on hemophilia A because hemophilia A is significantly more common, but they only have about 1 year of follow-up data so far. But what they're using in this new therapy is gene therapy. And in this gene therapy, they're actually supplying the missing gene using a modified virus. This modified virus that carries the missing gene goes to the liver, and in the liver then, with this modified virus carrying the gene, is actually able to make clotting factors. So I would encourage you to stay tuned to the news and how our science continues to grow and develop. Now let's talk about von Willebrand disease. Von Willebrand disease in some books and in some articles is classified as a hemophilia, although it's very different than the ones we just talked about. Von Willebrand disease is once again an autosomal dominant disorder, but this is an inherited bleeding disorder. So this is autosomal dominant, inherited, and it's a bleeding disorder that is characterized by the lack of von Willebrand factor. So again, autosomal dominant, we need one gene, not gender linked. So what happens here is, again, let's kind of move back and let's talk about what should be happening in endothelial injury. When you have an endothelial injury, von Willebrand factor, collagen, and fibronectin all have to work together so that platelets aggregate and stabilize. So what happens in von Willebrand disease, you have decreased level of von Willebrand factor because of the genetic defect. So you don't have sufficient von Willebrand factor. As a result, then, you have decreased platelet adhesion. You don't have enough of the factor to cause that platelet adhesion at the site of the injury. Therefore, you will see bleeding. We also know that, as we talked about just a few seconds ago, that von Willebrand factor also helps stabilize factor VIII. But the disorder here is a genetic defect in which they do not have sufficient levels of von Willebrand factor. Now, how is this different from TTP? Yes. In von Willebrand disease, you have the decreased amounts of von Willebrand factor. In TTP, you had enough von Willebrand factor, but you didn't have the enzyme to break it down, to make it active. So be sure that you have TTP and von Willebrand disease clearly separated in your cognitive thinking. The last disorder we'll talk about is DIC, or disseminated intravascular coagulation. DIC is both a coagulation and a fibrinolytic cascade-activated disorder. Now, generally we see DIC in high acuity environments. This is usually in the presence of an acute multi-system illness and therefore is a complication, not a primary disorder. It's estimated that as many as 20% of critically ill individuals develop DIC, or disseminated intravascular coagulation, and it carries a fairly high mortality, anywhere from 45 to 75% of those individuals who develop the disorder. Now, there is actually both an acute and chronic form of this disorder. However, the acute form is much more common, and the acute form of this disorder is in the acute form, the bleeding part of the disorder predominates. In the chronic, less common form of the disorder, the thrombosis form characteristics tend to predominate. So what is DIC? DIC is an acquired syndrome. Okay, we know that because it's a complication, in the presence of others, that is characterized by intravascular activation of coagulation. So there's this very important, it's acquired, and it's the intravascular coagulation, activation of coagulation without a specific localization. So we know it's systemic or disseminated, and arising from different causes. So let me read through that one more time, because it has some really good pieces. It's an acquired syndrome characterized by intravascular activation of coagulation without a specific localization, and it arises from different causes. And this is the definition from the International Society on Thrombosis and Hemostasis. As previously noted then, high acuity environments, and it's a sequela with a multisystem effects: disseminated, intravascular, and coagulopathy. All right, so let's then go through these steps, because and we're going to go through these steps because, as we've talked about, this is potentially life-threatening, and that's why we include it in our pathophysiologic disorders. So what happens then is you have someone with multi-system disease, or an acute trauma, sepsis, respiratory failure, pancreatitis. So you have the release of procoagulants as part of that inflammatory response. That then activates coagulation factors. And coagulation is activated. Remember, this is physiologic. We're supposed to do this to protect and limit areas of damage in that inflammatory response. As a result, then, we develop thrombus. So the body does its job, and fibrin is deposited. Because this is systemic or disseminated, this is widespread and fairly widespread deposition of the fibrin, not just at a site of an injury. Now, the body has done its job, it's deposited the fibrin, so now, as it should, the body initiates physiologic fibrinolysis. And with that physiologic fibrinolysis, fibrinolytic degradation products then begin to attach to the platelets. This is a problem, because then the platelets then are unable to adhere because their receptors are full, and then they continue to carry, and as a result then, we continue to carry those coagulation products, and we continue to clot. This then results in diffuse thrombus formation, especially in those small vessels. That then consumes a lot of coagulation factors and platelets, that then leads to bleeding. So what do we have again? A consumptive coagulopathy, because we keep clotting, and so we're consuming all of these products. And because we've consumed all of these products and we're not getting them broken down, they aren't available to actually do their job, and so then we bleed. The major manifestations of this disorder then would be petechiae, remember the platelet effect, a shock syndrome, as well as overt bleeding. So if you did a test called a bleeding time on this individual, you would see a very prolonged bleeding time. Most of us, if you cut us, if we put a cut on our in our skin, it's going to clot off within 2 to 3 minutes. These bleeding times are longer than that. You'll see this in your practice environment if you put a line in and you can't get them to stop from the puncture site or from a venipuncture. So the underlying disease or injury stimulates a very strong procoagulant activity, and we produce too much fibrin. That then overcomes the anticoagulant control mechanisms, thus we build thrombus, and that allows it throughout the system. That's why you have both bleeding as well as you have microthrombi. So what would your labs look like? What would your prothrombin time be? Yes, it's elevated. What about your APTT? Yes, it's elevated. What would your platelet count be? It's going to be, you're going to see some decrease in your platelet count. What if you measured a fibrinogen level? Yes, it would also be decreased because remember you're consuming it. Now the other thing we'll often see in these individuals, if you look at their red blood cell count, you'll see schizocytes. Remember what were schizocytes from the anemia lecture? Abnormally formed. They're being fragmented because they're being pushed through those tiny little vessels that are microthrombotic. The other test that sometimes you'll see done in DIC is a D-dimer. And D-dimers actually measure fibrin degradation products or fragments. And so if you're measuring those degradation products and fragments, D-dimers tend to go up, but it's not an especially sensitive or specific test. And so plus minus on whether or not you're going to use that as you're looking for this as a manifestation for the pathology. It helps us rule the pathology in, but never rules it out. So we've talked a lot in this lecture about clotting. We've moved a little bit between normal and abnormal so that we could understand when you lack something how it manifests in an abnormality or a pathophysiology. So it's important that we understand that clotting mechanism and the factors if we're going to be able to manage patients in our therapeutic management. We know and we've talked about how clotting can be interrupted both through the intrinsic as well as extrinsic pathway. We know how to measure them. And we know that both hypo and hypercoagulopathies can occur both as genetic as well as acquired pathologies. I know this can be confusing. Or feel confusing until you really dive in. So you're saying, so what do I need to know about this? Can you differentiate between the bleeders and the non-bleeders? Do you know the elements of Virchow's triad and the contributions that those three major pieces make or have to the formation of thrombus? When we talked about the inherited disorders, are they dominant or recessive? And if we change factors, how do those change in factors lead either to an increase or a decrease in the ability to clot? Let me know if you have any questions, and as I always do, I appreciate